A 35-year-old male presented with diplopia. I am showing you a coronal T1 weighted orbital MRI scan. Describe the findings.
Okay, assessing the provided imaging. The coronal T1 weighted MRI of the orbit demonstrates marked bilateral enlargement of the extraocular muscle bellies. Specifically, there is prominent thickening of the inferior, medial, and superior rectus muscles. Crucially, the distal tendinous insertions of these muscles are completely spared, remaining thin and normal in caliber. There is also mild retroorbital fat hypertrophy and early bilateral proptosis.
I am showing you corresponding axial CT images. What do they demonstrate?
The axial CT images through the orbits confirm marked symmetrical thickening of the medial rectus muscle bellies. The insertion of the medial rectus tendons onto the sclera is clearly spared, creating a spindle-like or fusiform muscle configuration. No bony erosion or abnormal intraorbital mass lesions are identified.
What is the diagnosis? Explain the pathogenesis and gender predilection.
In that case, the diagnosis is thyroid ophthalmopathy, which is also referred to as Graves' ophthalmopathy. Pathophysiologically, this autoimmune disorder involves the deposition of mucopolysaccharides and glycosaminoglycans within the extraocular muscle bellies. This deposition is accompanied by inflammatory cellular infiltration and retroorbital connective tissue hypertrophy. Clinically, this disease typically presents in adults and exhibits a strong female predilection.
What is the key differential diagnosis? How do you differentiate it radiologically and clinically?
Well, the primary differential is orbital pseudotumour, also known as idiopathic orbital inflammatory syndrome. Orbital pseudotumour characteristically involves both the muscle bellies and their tendinous insertions onto the globes. Furthermore, pseudotumour is typically highly painful and more commonly unilateral. In contrast, thyroid ophthalmopathy is usually painless, bilateral, and demonstrates tendon sparing.
Discuss the frequency of muscle involvement, clinical features, and management. How would you manage this patient as a radiologist?
Okay. The typical frequency of muscle involvement follows the mnemonic I'm slow, representing inferior rectus, medial rectus, superior rectus, lateral rectus, and oblique muscles. Clinical signs include proptosis, lid retraction, lid lag, and restricted ocular movements causing diplopia. As a radiologist, I would recommend immediate laboratory thyroid function tests and autoantibody testing to assess for hyperthyroidism. In cases with visual disturbance, I would recommend urgent ophthalmology referral for high-dose systemic steroids or surgical orbital decompression to prevent optic nerve compression.